All right. Hi, everyone. Welcome back. I hope you enjoyed the COVID session. Very timely. We are going to start with our shared treatment decision-making panel. Remember, there is that Q&A box to the bottom left-hand side of your screen, which I will be looking at throughout the panel to make sure we get your questions answered. First, I would like each of our panelists to introduce themselves. We have Dr. Pedro Barata, Dr. Katie Beckerman, and Bruce and Susan Hill. So Dr. Barata, I think I can start with you.
Sure. Hey, everyone. My name is Pedro Barata. I'm a cancer guy. I'm a medical oncologist with focus on kidney cancer. I work at Tulane University, New Orleans, Louisiana. And it's a pleasure to be here. And thank you so much, KCA, for having me. And I'm looking forward to this discussion today.
Great. Thank you. Dr. Beckerman?
Hi, everyone. My name is Katie Beckerman. I'm an assistant professor at Vanderbilt University, and that's in Nashville, Tennessee. I have been on faculty here for a few years. My research and clinical focus is in kidney cancer, and so I'm excited to be a part of this and look forward to the chat.
Great. And Bruce and Susan?
Hi, everyone. My name is Bruce Hill. I'm a stage 4 kidney cancer patient, diagnosed in 2017, had a right radical nephrectomy. It did metastasize to my lungs, so I was treated with only 2 doses of Ipi-Nivo or Opdivo/Yervoy. So far, or since then, I've had pretty much a complete response. So I'm not currently under any treatment. We're just continuing on 6-month scan schedule right now. And I'm treated at MSK, Memorial Sloan Kettering in New York.
And I am Susan. I am, sorry, the mailman's here. I am Bruce's wife. We've been married for 25 years. We have 2 kids. I am his caregiver, happiness manager, chef, all of that.
Great. Welcome. Happiness manager. I like that one. We had chief support officer earlier. So these are excellent titles. Oh, check the mail. So shared treatment decision-making really in its simplest form is when the physician and patient can make treatment decisions together based on shared goals rather than the physician being more prescriptive about the treatment. But I think it's first important to understand for people living with and affected by kidney cancer, how physicians make those treatment recommendations or how they come up with them. So Dr. Barata, I'll start with you, but if you can talk a little bit about the process that you utilize to make treatment decisions.
Yeah, thank you so much. That's a great discussion and a great question. And I guess the answer won't be that simple. I'll try to keep it short. There's a lot of factors, right? So, when you see someone, when we have a patient walking in, and ask us about the plan that might require or not medical treatment, right? There's a number of factors that we take into consideration, here, but it's also common for a lot of institutions where you can go. So it's important to know what type of kidney cancer we're talking about because that has huge implications in the way we address it. It's also important to know the staging, meaning exactly where we have disease, because that also impacts how we address one with kidney cancer. I'm just going to use renal cell carcinoma, as the vast majority of kidney cancers are indeed renal cell carcinomas. And, most of the times when they come to see me, is for patients with stage 4, meaning disease outside the kidneys, in other places of the body, just as we heard from Bruce, in the lungs or other organs. Lung is a very common place for renal cell carcinomas to go to. So, location of so we call that metastasis, disease outside the kidneys. So, location of disease, type of renal cell carcinoma, we call that histology. Risk factors. So there's this score. We come together with a number of factors, and we understand what's the risk. And a lot of what we do, our treatments are well suited depending on what risk a patient with renal cell carcinoma actually have. So that's another one. We oftentimes require labs for part of that risk score. but also for us to understand, what's the ability for us to deliver certain treatments. And then, specific other factors that are truly, truly important, such as distance from the site, right? In Louisiana, have patients come see me and drive 3-4 hours away. And I try to understand exactly how possible it is for them to come and see me, every 2 or every 3 or every 4 weeks, versus staying closer home and kind of have me to touch base with local teams to help the best treatment. So distance is important. Patient preference is also important. Patient and, significant other or family preference is also important. Often at times there's more than one absolute correct answer about next step. So we have that. I think that discussion is important. Other factors that I think are relevant, are the knowledge the patient has about it. So sometimes I try to break it down and not overwhelm with all that information on day one. So oftentimes for us to come up with a plan, it requires sometimes 2 visits, more rarely 3 visits, but in 1 or 2 visits, most of the times we have a plan together. But another factor is physician choice. So I know some colleagues, especially in the community, are less comfortable with some treatments and prefer other treatments. And again, when there's more than one option available, nothing wrong with going with a treatment that a physician is also more comfortable with. And it's also important, each patient is different, right? And so some patients have a significant past medical history, meaning other problems, right? Health-related problems that may or may not impact our ability to treat him with the treatments we have available. And finally, I try not to make decisions based on finances, as I call it, based on the wallet. Most of the times I couldn't care less about that, because I truly believe we should offer the best we have available, regardless of our financial situation. And it does require a good financial office that works with us, to come up with solutions. So the way we go is we offer the plan. We say it, let's try and find the best plan in the world for you, and then we'll make that happen, and not the other way around. So that's a number of factors, and I would argue some of these are common to different institutions. Others are a little bit more specific. So in Louisiana, patients don't like to cross bodies of water, right? For instance, and they travel more than other sites. So that factors to me carry a little bit more weight than in other sites where it's relatively easy to get to the institution where they get their care. So I'll stop there. We can expand on a lot of these factors, but I'll stop there for now.
Great, thank you. Dr. Beckerman, what would you add to that?
Yeah, no, I think I would highlight and agree with all of the complexities that Dr. Barada has presented, that, the first thing I do when I'm meeting a patient is try to meet them where they're at. And I do that by asking them, what do they want to accomplish out of that visit? Try to get a sense of, are they someone who has a specific fear, a specific concern, want a specific issue addressed? And then all of us kind of come together. I always welcome questions and really encourage. It's just so much to hear. It's so much to hear, and just what Dr. Prado was saying, in one visit, it's almost nearly impossible. And I think it takes multiple visits, but I really encourage that it's like a long-term relationship that we're starting together. It's a marathon that we're going to be in together, and we have to work together to get through it. So I agree that when I think about each person, I like the term personalized treatment. I think about that, though, in kidney cancer more so based on the person sitting in front of me, and less so on what, as cancer doctors, we often think of from a biomarker treatment choice, because we don't really have great biomarkers in kidney cancer. So I think more about, again, I agree with Dr. Barada, I think more, what are the medical comorbidities? What treatment options? What's the travel like? What clinical trials do I have to offer a patient in any specific situation? And we kind of go through that over 1 or 2 visits, and really answer questions and come up with a plan that we both are comfortable with.
Great, thank you. And then Bruce and Susan, turning to the patient and caregiver perspective, if you can share a little bit about what your journey was like to diagnosis and ultimately making those treatment decisions.
Yeah, I had quite a long journey to diagnosis, actually. 2 years prior to my diagnosis, I kind of popped up as anemic on a routine physical. And so that kicked off a long investigation through multiple blood tests, extensive blood work, to the point where, and that was with a hematologist, oncologist that I worked with initially. And we actually got to a point where the anemia went away with some iron supplement treatment. And I, you look back now and say, I wish I had been a stronger advocate for myself in that spot, because something else was wrong. It wasn't just an iron deficiency, but I didn't know enough. I didn't have the knowledge to know that's a potential sign of a cancer situation. So I kind of said, okay, I'm better now. I'm not anemic. And by the way, I had another physical a year later, and I still wasn't anemic. I wasn't on the iron supplements anymore. So it was very strange, right? So I guess I felt fine. Then again, a year later, I started actually feeling run down and tired, and starting to look pale and feeling that maybe I was anemic. And when I went to a doctor, as soon as the doctor walked in, she said, "You're anemic again." And she didn't even have to do a blood test. She could just tell by looking at me it was that bad. So that kicked off a whole other series of tests back to the same hematology oncology practice. And it wasn't, that included, besides the blood work, a bone marrow biopsy, a full workup of endoscopy, colonoscopy, all of that, looking for bleeding, right, internal bleeding. And nothing there was found until I did present with flank pain. And when that finally happened, that's when we ended up with an MRI and a CAT scan, and that's when it was discovered. So, I look at that journey and think about how, if I had been a stronger advocate for myself and tried to dig deeper into what was going on originally, we probably would have found it when the cancer was very small. And maybe I could have just had a partial nephrectomy, and maybe it wouldn't have metastasized, right? Hindsight is 2020, but that's why I think. And now that I'm a kidney cancer patient, and I have gained a lot more knowledge about the disease and a lot more knowledge of the different the treatment landscape that exists today or existed a year ago when I actually had my treatment, or actually 2 years ago. Things are changing so fast that having that knowledge and being able to attend events like this, or using resources like the online forums where you can find information, and having that knowledge really gives me the strength to feel confident when I'm talking to my doctor. So that's kind of how we've gotten to this point. And so when we made the decision to start treatment, which was, after the nephrectomy and after the cancer was discovered in my lungs, and it was confirmed to be a thoracic wedge resection, that's when I went to a genetorial oncologist who, an expert in kidney cancer, like the two doctors we have here. And that's, it was that point where we decided to scan and watch for a while, and that lasted for almost a year. And then when we had to make the decision, as things started to progress in my lungs, that we needed to start treatment, we came to a common decision, and I was armed with that knowledge because I had already done the research and talked to other patients through things like online forums like Inspire that KCA has, or Smart Patients, which is another great source. So again, having that knowledge, I think, really gives you the confidence to be able to make a shared decision with your oncologist.
Great. Thank you for sharing that. And Susan, your role as caregiver, and how did you help make that decision, or kind of what was your thought process as you guys were going through this?
Well, like Bruce said, he was very pale, and we were on a hike. I think we were at Joshua Tree, and he couldn't keep up with the rest of the family. And the kids and I said, what's wrong with you? You need to see a doctor when we get home. So he did, and that's when we started on this journey. But I do want to add that we've been sort of very open and honest with all of our friends and family about this. And, I post on Instagram all the time. And, when we try to share our story, with like in cases like this, because we want to make sure that people don't ignore, those symptoms, and, do advocate for themselves, and try to get to the root cause of, why you're anemic, or why you might have night sweats. That was another thing. Bruce had night sweats. And, again, we didn't really pursue that. I'm not even sure you mentioned that to your doctor, but that is a sign, of cancer. So anyhow, we just, we try to talk about it as much as we can. So if we can help one more person, get the diagnosis and treatment they need, then that's a good thing.
Yeah. Well, thank you. I appreciate you guys always being so willing and open to share. It's fantastic. Let's go back. We'll go back to Drs. Barada and Beckerman. And if you talk a little bit about how you set expectations with your patients about their treatment options, and, what side effect management's going to be like, and just kind of how you have those conversations with expectations.
Yeah, I think it starts with, again, in that initial meeting when we are kind of coming up with the plan for what treatment we're going to do. And side effects really, they can matter. It matters in the context of what you might even consider starting a patient on, whether it's safe or not, if they have heart problems or prior autoimmune problems. It might matter what therapy you end up choosing for a patient. So I'll try to describe the benefit that we are using for the goal of a treatment, but also I really try to go through the risks as well. And I also find it's helpful to hear it from multiple people on our team. So I'm very lucky to work with both a nurse practitioner, a physician's assistant, and a pharmacist, so that we kind of have like a little bit of a team meeting, that first time. And again, I agree with Dr. Barada before. It really is multiple times. And I do try to emphasize that that first meeting, you might glaze over, you might only hear part of what we're saying, but we'll revisit it again and again because, things change. You think of other questions, that kind of thing. And so, regarding expectations, I use the similar IMDC criteria, which is what Dr. Barada was referring to. There's different prognostic features that we can look at in patients who present with kidney cancer where it's left the kidney and traveled elsewhere. But to be honest, even those prognostic features that we have were based in a time 10 years ago when we had different treatments than we do now. And so I even try to put it in that context that, we think we're making advances in all the treatments that we have. And we really don't know for each individual person. I don't have a blood test. I don't have a predictive way to say, I think this is the best for you. I try to say, we have these many different options. And the way we best can tell if this is going to work is, unfortunately, to try it and then to monitor with imaging. So I don't know if that helps.
Yeah, absolutely. And Dr. Barada, anything to add?
Yeah, I was thinking, and that maybe that's a problem of academic people like me. We tend to like numbers, and we share numbers a lot. We talk about numbers all the time. Some of them, are not easy to get. Stuff like hazard ratios, median survivals, median PFS, etc., overall response rate, and all that. It's very easy for us to start having such a complicated conversation that it's hard to get sometimes. So, so when and I'm at least for most of my patients, they expect transparency and they expect honesty. And what they want us to do is to be on their side, whatever happens. And yeah, I actually say that a lot. When I have good news, I'm going to be sharing them. And when I have bad news, I'm also going to be sharing them because they count on that. And so I use a little bit of my my palliative care background. I use a little bit of a protocol, which is a 6-step where you first assess, or you keep this nice atmosphere environment as you do when where you should have it in clinic, and then you understand how much the person in front of you knows and family, and also how much they want to know, right? And so I try to adapt my language and my communication and that information to how much the patient want and the person who's in front of me want to know. And some love numbers, and to the point where I actually go over the New England's, and not only New England, for example, and I print them out and we go over the abstract to explain hazard ratios, response, etc. And they love that, right? That's and that's what they want to hear. Others, they say, Doc, I don't want numbers. I just want to keep it simple. What do you think we should do? I'm going to follow that. Let's do it. And so before I just jump in and do my, and I try to understand where are we and what kind of language I'm going to use. I don't change the information. I just, kind of break it down differently based on who's in front of me. Because I might be an Einstein or not, but, if I'm not able to communicate what we're going to do, and not, and address the person in front of me's needs, right? I'm not doing a good job, in my opinion. And so I try to do that. And the reason I bring that up, because, people are very, very different and they expect very different things. So expectations are very different. And so often I assume expectations are one type and they happen to be quite different, And so, I try to remind myself of doing that every single time I see a new patient. So that would be one thing that I try to do. And the other thing is, people are not numbers, right? We treat numbers. We don't treat scans. We don't treat, we treat people. We don't treat numbers. We don't treat scans. So, so when people ask me, and that question comes quite a lot, they read online, they know about it, especially in the context of stage 4. What's my prognosis? What's my survival? What should I expect from this treatment? How long it's going to work? The numbers we have are just that, are numbers, and they represent is a statistic like anything else, right? And so I also have this conversation about what is stats and what is reality. What is stats and what's the individual, right? Because for you, is either, as my mentor used to say, is either 0 or 100%, right? Either works or not, And the numbers happen for, if you think of 100 people in a room, that we usually use numbers for half of that 100 people, right? But it doesn't tell us about the individual in front of us with that problem we need to help. And so when we talked about expectations, I often have that kind of conversation and try to bring, translate numbers into people and translate what we know and how we move the field forward and how that translates into the person in front of me, and the significant other in front of me, what that means for them, right? So this is better said than done, right? It's easier to say that than do it. We try to do that because we talk about numbers all the time. That's all we do, right? So anyway, that's probably one approach to expectations, I guess.
That's great. Yeah, I think that's really important, is to make sure that Megan Conley just said that in the last session, in the COVID session, about how to physicians to remember that the person that you're talking to is scared. And, like you said, they might want to hear those numbers and they're going to go home and do that research and look at those hazard ratios. But sometimes they just want to make sure that they get to their, grandson's game or, whatever it is, whatever's important to them, in their life. Bruce and Susan, what were really your expectations when you started to work with your physicians, and how did you adjust as you went along?
Yeah, well, so one interesting thing, as I mentioned, after we confirmed that it was stage 4 and I started to go to Memorial Sloan Kettering and meet with the oncologist there, he walked in and, first he said, okay, we need a new set of scans. So we did a new set of scans. And he said, at this point, all of the presumed metastases that are still in your lungs are, sub-centimeter. They're too small to really measure anything or any changes. So we're not going to do any treatment right now. And I was absolutely expecting to, okay, here we go. We're going to start treatment right away. So that was a bit of a change to what we were thinking. I think both of us were thinking.
We wanted to start treatment right away. Let's get rid of this.
Right. So we actually went almost a year of 3 month scans, and until it started to progress. But along the way, every time we had a post-scan meeting, a discussion, we talked about the treatment landscape and what was happening right now, right? What's new? What's been recently FDA approved? By the way, Ipi/Nivo was FDA approved about 2 months before I started it. So that was those were good discussions, and we started talking about the potential treatments and then what the side effects were, like Dr. Beckerman said, what are the side effects that we're going to may have to deal with based on whether it's a TKI, a targeted TKI therapy, or if it is an immunotherapy, what kind of side effects you might have to deal with then. So we were already starting to process that even before we got to the point where we had to make a decision and go forward with the treatment. So as we led into the next to last scan before we made the decision, my doctor said, I think at the next scan, we're going to have to make a decision. So let's talk about, now what is it that we think we're going to do? And we were leaning towards the Ipi/Nivo as the choice at that point. And that's, what we ended up going with. But I think the fact that we had all that time leading up to it and had the discussions along the way, and we were, kind of bouncing ideas off of each other really about what to do. And I have my notebook here. I think in the previous session, it was talked about a lot to have your notes available. And so, there's notes in here, some of the first few pages about what are the different treatments and what are the side effects you have to deal with. So we were talking about that all along.
Right.
Anything to add?
Of course, and I lost my train of thought. We write questions in the book in between meetings with the doctor. So when we get there, we're able to ask those questions and we write down the answers. We record your lab results. You talk about numbers. We study those lab results when they come back because Bruce actually had a reaction because you only did 2 treatments. He had
autoimmune hepatitis.
Yes. And so he had to stop his treatments. He was supposed to have 4, but he only had 2. And as caregiver, it was up to me to kind of notice he was taking a prophylactic antibiotic. Well, it turns out he's allergic to many of them. So he broke out into this horrible rash. So, it was up to me to say, what is going on? What is that rash all over your body? So he was getting blood work every other day to, so we could get a handle on this hepatitis. So, understanding what those numbers are, understanding, when they need to go up, when they need to go down, and, being able to recognize, those side effects, and calling your doctor with any side effect. They said, don't be afraid to call us with any side effect. So we did that. Yeah. And, and it is a team. Like we didn't always talk to the doctor, but we might have talked to the nurse and, she would talk to the doctor. It's one big team and it's so important.
Great. Well, so you showed your notebook, so that was actually a perfect segue into another topic. And we saw Michelle's earlier, her great binder, which made me a little jealous with all that color coding. It was pretty well put together. But Dr. Barad, I'm interested to hear, and Dr. Beckerman, what you've seen from patients and families that have come into your clinic and how they prepare for appointments and what tips and tricks that you might have.
Yeah, definitely. I encourage. So one thing that I do a lot is actually having people call in and FaceTime. So I actually love when I have, when the patient brings someone along, or, and I actually ask, when I don't see anyone else, but I always ask, hey, is anyone else you want to be on the line, just to listen and ask questions, because it's important. This is going to be a lot of repetition. I'm not expecting you to get 100%, not because you're not a smart guy, but because we're talking so much about so many different things. And, they're going to sound very, it's normal to get them confused or hear something different. So it's good to have everybody that you trust hearing the same stuff, and we go over these as many times as needed. But, but it's cool if you want to have someone, it's fine to do it. So actually, most of my appointments, I have a phone or two phones, but, on. And so that's one thing that I do. And I find it helpful. The other thing is I always have handouts and written information. The other thing is I'm a board guy, and, I like papers and kind of do drawings and stuff like that. So that's just, I think it can be helpful sometimes, because I usually am asked when I don't have paper something, right? And it's like, hey, can I take that home? It's like, sure. I mean, that doesn't look good, but are you sure? So that happens quite a lot, actually. And so, but, we all have our own way of presenting what's out there, right? I also happen to have a lot of students with me, or residents. And so oftentimes we do have some discussion outside the room, but interestingly enough, a lot of the discussions I have with students and residents actually happens in the room with the patient, and that's so, and that's actually quite cool, because we try to break it down, but the goal is for all of us in the same room have the same level of knowledge about what we're talking about. And quite surprisingly, you have people who are med students, no oncology background, patient and family, right? Residents or fellows, and they all, have different questions, but at the end of the day, believe it or not, that makes sense to all of us. And so that is important, because, as I usually say, when I step out the room, the goal is everybody knows the same, everybody is comfortable with what we've talked about and what are we going to be doing, having a plan, right? So coming up with a plan is also very important. It doesn't mean we know the answers, but we know what the next steps look like. Even if the next steps will answer the questions that we don't have an answer today, right? So for instance, is this going to work? We don't know. We might say likely, unlikely, etc. But sometimes we don't know. But we define a plan to find out the answer to that question, right? And when there's no answer, we got to say it. So having a plan, having written information, KCA material and other materials, super, super important. Having a team, as Dr. Beckerman said, I mean, that's so important. I'm in a unique position where I actually share my cell phone with my patients. And that's for a lot of reasons in regards to the region where I'm at. You'll be surprised. I think it's less than 5% abuse from the number, in all honesty. But to Dr. Beckerman's and to Bruce and Susan Hill's point, it's so important for us to find out when something is not right. We find out about it sooner rather than later. That makes such a huge difference, And so in my situation, it's so good that they have a good access, to me if they need it, and that we can put something together that sometimes makes a huge difference for them, right? Detect adverse events sooner rather than later. Send them to the emergency department because something is happening and that's not right. Titrating medication, holding medication for whatever reason, doing that lab. So anyway, having a plan, as it was emphasized here, and having a team working together, and also having access to that team, no matter, in my case, is a lot of times it's me, but having the pharmacy, nurse practitioner, physician assistant, is truly, truly, truly important in my opinion, and is a great way to success. I usually say, that a lot of times it's not so much what we know, the knowledge by itself, because a lot of times I usually say this, it takes a monkey to prescribe a medication, and I think what makes us different, in my opinion, is why we're doing A or B or C, whatever A, B, or C might mean. I think what's truly important sometimes is, stress out the important things, pay attention to the important things, relax on the things that don't deserve our attention, our energy. And ultimately, the plan might be the same, but it's quite different when we do it alone or we do it with the team that is that walks side by side with you. I think, to me, that makes a difference, and that's what we try to accomplish when we want to see patients with renal cell carcinoma.
Thank you. Dr. Beckerman, have you seen any ingenious ways that patients and families have come in and prepared for their appointments?
I think I truly light up when someone comes in with a bag of information and their book. I love that. Having too much is there's no such thing. There's just so often, because of our healthcare system, that someone is coming from 3 hours away and they think all the information has been sent by their local provider, but I don't have the CT scan, or I don't have the most recent biopsy result. And so for a patient to come in literally with this great book of, look at all this information, then if something's missing, that's a great resource. And then I agree, it has, and this kind of goes back to that COVID talk that I was able to hear a little bit on. That's changed things, because at our institution, we're only allowing one caregiver per patient to come in for visits. And so I do a lot of the phone thing as well, because, often you're supported by an entire family, friends, other people. Some may have medical knowledge and you want them to be listening because they might grasp, the information you're giving. So I definitely agree. And, either if you can't have someone right there offering their ears, that you're, doing a Zoom or at least a phone call, to share that. I also, so I'm glad Dr. Barada said the same thing, because I also write on paper towels, which I try to be more professional and bring a notepad or something, but I often have forgotten it. And I think that just, you do just hear so many things. So besides providing written information, maybe on the medications that you're talking about or the side effect list, because those we can print off, from great resources and things, but I will write down, because it's so much. You're about to tell them, okay, now you're going to go to the lab, you're going to get this blood work. Before you leave, I need you to check out. Don't forget the checkout desk, and you've just told them all these, so many of my patients just have to listen to all this information and absorb all this, and it's too much. And so I'll try to write all those things down, kind of the rationale of what we've talked about, what the plan is, and, what the next steps are. So I encourage support. I encourage, writing it down and writing your questions down. I think that I do see a difference for people who come in with their written questions, and I never mind that. I would rather you have 2 pages of written questions and get them all answered. And then the last thing that I do before, especially at a new patient visit, is I verbally tell my patients, you have to advocate for yourself. If you call after starting treatment and you've got a side effect and you're worried about it, and somebody tells you it's no big deal and that wasn't the right response you wanted, call back again. Message me, whatever. I want to make it so that you're comfortable. If you don't get the answer you want, if you don't understand why the scan was moved up, moved back, whatever, this is a two-way team. You have to communicate for me. And so in that way, I really urge that we're building this trust relationship, that I can trust that my patient will tell me they're having a side effect so that I can act quickly upon it. And that I want them to trust me, that I'll be, again, open, honest, about, what's going on. So that's a lot to accomplish in a first-time visit. And so that takes, again, several trips. But those are my tips and things that I've tried.
Great, thank you. I do want to address one of the questions we have. And Dr. Barati, you talked a little bit about this before, maybe not so directly, but the question is sort of how much do doctors have to work within Medicare regulations or within insurance regulations? You want to prescribe treatments that are potentially costly or not covered by insurance. So how do you manage some of that with your patients?
Sure. And again, what I'm going to say might be state specific, and we live in a crazy world, and there are a lot of different ways of dealing with this. I have the luxury, I guess, of not worrying at all with the insurance. I actually don't even look at it. And the reason being, first of all, I'm on the providers list for all the health insurances. I think that's important. But the reason why I know that is because the patient won't be able to see me if I'm not. But so one of the things that I did when I got to Tulane was make sure I was on the providers list, just because it gets rid of a lot of obstacles in related to that. And I did because I was sold as a kidney cancer guy, right? So oftentimes it helps when and this is for providers, right? Because a lot of times the same institution has a different number of providers on the same payer, and so you being the go-to person for a specific disease helps with that. So he helped me in my position. So I see the question here, and I happen to have a lot of my patients do have Medicare. I don't remember running a lot of problems with that. The way we work is, again, I work, I see a patient, and I don't even know what insurance they have. What happens is afterwards. So once we come up with a plan about what to do, everything we say when we want to get done, right? We put the orders in for whatever it is, and then we run an authorization process, right? And then, you can have one of three outcomes, right? It's either approved, that's it, or it gets approved with a financial burden of some sort, or it gets denied. And so for the ones that got approved with no issues, then that's it, right? So I shouldn't address, I don't spend a lot of time on that. With the denials, believe it or not, I would argue, at least where I am, the denials have been minimal. In reality, for kidney cancer, I haven't got a denial yet. And we do use a lot of expensive medications, but part of the reason I suspect has to do with us documenting why we do what we do. Right. So I think documenting in our notes, in our discussions, everything we recommend is leveraged on data that exists for what we're doing. And when there is not level 1 data, there's level 2, etc. But document why we do what we do helps us to overcome some of the obstacles regarding denials. Sometimes we have to do peer-to-peer, meaning we talk to the health insurance. A lot of times that conversation actually go well and are very reasonable. Surprising for some, but, they go well, and, folks understand. And a lot of times that's just to do with some clarification that have to be done. So we do that as well. So that helps getting part of, the barriers. And then the high copay, or some degree of copay, I should say. We have our financial office, and different institutions have that different departments. What actually they do is they go out there and they find, diverse or different sorts of funding opportunities or programs where we enroll our patients to be able to minimize that financial burden, right? And for some, that goes down to zero. For others, it's adjusted to their level of what's considered reasonable, right? And again, I don't even know that. So just to see how that process goes in parallel to what we do. And kind of on purpose, I prefer not to do that because, again, I believe treatment should not be dictated by the financial aspects of it. So as I said before, we come up with a plan and we're trying to make it happen. In reality, the vast majority of patients so far that I'm aware of, at least, have not their care being impacted by what I just described as being the authorization process. But again, I'm not speaking, across the country. I know everything is different. I also work very close to the University Medical Center and the VA. So as you can imagine, there are ways that we can make things happen within the system because patients are engaged in different institutions depending on what their, health insurance is and their restrictions. And so I don't want to, I cannot be too specific because there are a lot of different characteristics depending on where you are, where you work, etc., your status. But what I have to say is, what I can say is most of the teams that I know, and I know it's true for Vanderbilt, Memorial, and a lot of institutions out there, they work hard and they work very closely with a financial department that can help to come up with solutions to the problem if there's indeed a problem. And that's kind of how I would, address. Now, specifically the Medicare, and just, to answer the question about scans, there is some degree of limitation about the number of scans for the same reason. So let me give you an example. There is appropriate, I'm glad Bruce brought it up, active surveillance. It's indeed a valid approach for patients with stage 4 kidney cancer, not for all. For a subset of those patients, we do offer active surveillance, meaning we don't start active treatment, but we keep monitoring, see how things go. Like, as everybody can understand, we do repeated scans, regular scans, but we cannot do scans every week, right? By the way, it would not be that helpful, but we don't do scans every week. As Bruce described, he got scans roughly every 3 months or so, right? So my point is, if we try to start doing scans every week, in the context of active surveillance, that probably won't be accepted, right? So the reason why, but that's different from a patient that's getting scans every 3 months, and then out of the sudden, he develops his acute back pain, and we are concerned about something else, right? You might have a fracture from trauma or from a lesion that might be getting worse, and that's a different reason to get the scan sooner than later. So this is just an example where you can get that scan approved afterwards, right? But if our goal is to stage us, right, we're not expecting to get those scans happen every week or every 2 weeks because they will be denied in that under those circumstances. So what I'm trying to say is, often helps when we understand why we're ordering something, having data to support that. Is, in my opinion, a good, an easy way to overcome some of the barriers. This is not the perfect world, so we all have challenges, right? I'm not saying we don't have challenges here, but what I'm saying is, most of the time, those challenges are being addressed in a positive manner, and obviously working with a team, in this case, getting a financial counselor as part of our team is helpful.
Thank you. I might just add to that real quick is, if it is something, and maybe Bruce and Susan, you can comment on this too, if you've had this experience or not, but, most of the time as physicians, if we've ordered something and it gets denied, we hear about it, but sometimes remarkably, at least for me, it sometimes takes a little while. And so that might be because my financial group doesn't go to approve the scan, even though I ordered it so many months ago. They don't actually go to approve it until just a couple of weeks before the scan is scheduled. Well, now all of a sudden the scan is denied. That denial could be, I didn't code it right, or the denial is the insurance company didn't see that it was for cancer, whatever, and it's just a mistake. And so I really encourage, and again, Bruce and Susan, I'll see if you guys have any comments on this, but if you all are the first ones to hear about it, sometimes we don't hear about it until it's like the day before. Oh shoot, their scan was canceled. Why was that? So again, another area where you can advocate for yourself, send your doctor a message and say, I thought you were going to scan me every 3 months. I'm being told that this is not being approved. And I'm already on the phone to the insurance company saying, what are you guys doing? Yeah,
I've definitely had that experience. And like you said, it tends to happen right, just before the scan is supposed to happen. And that's exactly what we've done. I've immediately jumped on either the phone or the message portal that Memorial has, and just said, hey, this got denied, and be aware of that. And they, like you said, they jump on it real quick, and it's usually resolved within a day. So definitely something to jump on right away if you get that denial, because it's a little, you're like, well, wait a minute, I know for sure we got to do this every 3 months or whatever. So it happened a few times with, especially with brain MRIs, which we've been doing as part of the scan, not every 3 months, but on a kind of an annual basis, and it happened there.
May I just add, that's a great point. I agree. And I should just add, to emphasize the communication between, patient and care team. Sometimes this is very automatic, So in other words, let's say, for instance, the scan is initially denied, but then the team is already on top of it and got it approved, right? It's possible that the letter was sent with a denial, and the letter gets to you, right, Bruce? 2 weeks after it got approved, and then one get confused because you have a date for scans, but you get a letter in your hands saying it didn't get approved, and you get your care team saying, "Oh, we got approved." So those things, again, no system is perfect, right? But those things can happen, and I believe when we have good communication, it helps us to kind of understand where we are. And in reality, we're all on the same page. We're all on the same side. But a lot of times it's so easy to fix just with a call or, with an email, what have you. And we get rid of that right away.
Yeah, absolutely.
Can't be
easy. If we don't do that, it creates a lot of anxiety, right? If we don't do that, it creates a lot of anxiety because we let a letter, because I'm saying a scan, but, I might say a scan, I might say the treatment. There's like, oh, shoot, the treatment got, it can create a lot of anxiety and distress. So you go both ways.
Yeah, I was just going to say that has to be so difficult to have to try to manage the healthcare system on top of managing your own cancer care. Not easy at all. All right, we have a little under 10 minutes left, but we had one more question in the chat here. The question was Bruce's original anemia a predictor of RCC, or rather, is anemia considered a possible marker of RCC? I don't know if Dr. Beckerman or Dr. Barati, you want to?
Yeah, I think, Bruce, as I was hearing your story, my heart goes out to you all. Unfortunately, anemia can be caused by so many things, right? And I do think you had lots of doctors who were trying to get to the bottom of this and doing lots of great studies for why. When we do look at patients who are diagnosed with kidney cancer that has left the kidney, it is one of the prognostic features that we look at when we're trying to understand how that kidney cancer is behaving. And so that, again, was based off of kind of old data over the last 10 years that we've just known it is can be a side effect and a prognostic feature of kidney cancer.
Yeah, no, I agree 200%. I was just gonna add that unfortunately, like prostate cancer, for instance, we do not have a biomarker in the blood, so it's not possible for us, to do a lab test and say, oh, shoot, you have kidney cancer, right? So that's why scans are so important in this case. Although so kidney cancer in the old days used to be known as a good diagnosis done by the internal medicine, like Dr. House and others, right? And the reason being, it's very possible that you develop kidney cancer in the absence of symptoms, meaning you're doing great, you're doing well, and then out of the sudden something happens, you get to the to the hospital, you get a scan for other reason, and you find it, right? And so bottom line is, anemia is associated with kidney cancer. It doesn't mean every time you see anemia, it's going to be kidney cancer. And so it's hard for us to say when we see a lab abnormality to call it, it's because of A, B, C, or D. I think the message that, Bruce, Susan, and then Dr. Beckerman made, I think is a very good point, is just address it, right? Go to your doctor, go to your care team and say, I have these numbers and those numbers don't look right. And why is that, right? And then all the workup is done to understand exactly why.
All right, just seeing if there's other questions. Nope. Maybe to wrap up, we'll have everybody share. Bruce and Susan, I'll start with you. Maybe just share one or two pieces of advice that you would have for somebody starting off on this journey and trying to make these decisions, or just general pieces of advice you guys have for the kidney cancer community.
Yeah, I mean, I think the one thing that I'd like to close with is use your resources, right? There's tons of resources out there for kidney cancer patients. KCA is a great one. The pharmaceutical companies themselves, right? If you make a decision on a treatment, For instance, Bristol Myers has an Opdivo NU program that you actually sign up, you get a nurse assigned to you to communicate during the treatment process. They sent me all kinds of information about side effects and what to watch for, a cookbook on what to eat while you're on the treatment. I mean, it was really amazing what they sent. So, you know, that's a terrific resource if you do get assigned a particular treatment. Your hospital and your cancer center is a great resource, right? There's nutritionists on staff, there's palliative care doctors, you know, all of that kind of stuff to help get you through the treatment. My health insurance company assigned a nurse to me when they found out I was going on the treatment. So again, there was another resource that I could communicate with. And then I already mentioned the online forums are some of them are really great, and you know, knowledge is strength. So use your resources and gain that knowledge.
And I would just add to keep a positive outlook, take each day, you know, one day at a time. Try not to think about, you know, your next scan in 3 months. Live your life in between scans. And I know scanxiety is real, but it doesn't affect us as much anymore because you can't do anything about what the scan's going to show, but you can do something with the results, and you can make, you know, your smart decisions based on those results. So, you know, live your life and be happy, and, you know, go hiking, and just live your life, and just, you know, try to manage this as a team.
Excellent. Thank you. And Dr. Beckerman, what are 1 or 2 things that you want all kidney cancer patients to know?
Yeah, I loved all those comments. I would just add to tell your team where you're at, what you need, what questions you have, and to advocate for yourself. And if you don't get the answer you like, ask again. Maybe they just didn't understand the way you were asking it, or what your specific concern was. And also about the resources. If you don't know what resources are available because you're a new patient, ask your provider team. They can also help provide a list of, most of the time, of all these different resources. So I would say those would be my tips.
Excellent. And Dr. Barada?
No, I agree. Powerful words. It's a powerful word shared by Bruce, Susan, and Dr. Beckerman. I agree. I would just emphasize, you know, and more than likely, you're going to have a kidney cancer community in your region. Reaching out to them is also great. It's a great way to have access to information. You know, kudos to Bruce and Susan are here with us and sharing, you know, this story is a beautiful story. You know, and so that's just something. There might be, it's more than likely there's a kidney cancer community. And if there isn't in your region, if there isn't, KCA will help you to connect with the folks you want to get connected to. And the other thing is, you know, unfortunately, not cases are success stories. You know, unfortunately, we have to do a lot. We have to do far more. We have a lot of brilliant people committed to kidney cancer world and research. There's a lot more to do. And so one of the things sometimes we can help is with clinical trials and second opinions. Second opinion doesn't mean it's a different opinion, but it's another way for you to feel comfortable with the care that you're getting. So I would emphasize everybody to, to search for a second way, a second set of eyes to go over your case and make sure things are happening the way they should be happening. And then the clinical trial is just another opportunity that you might decide not to do, but at least you had the option to think about that as one way, as a treatment option for you. And so it's better to have more options than less options. And so, reaching out and see who's running trials in kidney cancer and connect with other people with kidney cancer, such as, through the KCA is an easy and very powerful way for you to advocate for yourself, as Bruce, Susan, and Dr. Beckerman has said.
Excellent. Thank you, guys. I was going to say push all the KCA resources, but you guys did that for me. So thank you. The one takeaway I kept getting, and this came up in a meeting earlier this week with our clinical advisory board, was about side effects. That when you have a side effect, call your healthcare team immediately. Don't be afraid that it's necessarily going to get you off your treatment. It's just something they need to know. So that's been a big takeaway this weekend for me. So we'll make sure through the KCA that we keep letting people know that as well. Don't be afraid. All right, thank you. We're going to end 1 minute early. We're keeping on time here. Thank you guys so much, Dr. Beckerman, Dr. Brada, Bruce, and Susan. This was fantastic. We're coming up on another 15-minute break, and we'll end the day with a side effect management panel, discussion. So thank you guys very much, and we'll see you back in about 15 minutes.